Now, most sonologists and sonographers actually don't image the heart. It's almost like there's a no-fly zone somewhere between the gallbladder and the thyroid. However, if you work in the developing world, I want to encourage you to learn a little bit of echocardiography, especially echocardiography involving the valves of the heart. So why is that? Well, the World Health Organization says that there may be 12 million people around the world who have rheumatic valvular heart disease, and the incidence varies tremendously from country to country. In the United States, the incidence of rheumatic valvular heart disease is 0.25 per 100,000. That means you have to scan 400,000 people before you see your first rheumatic valvular heart disease. But if you go to Africa, for example, in the Sudan, the incidence is 100 per 100,000. In China, the incidence is 150 per 100,000. In Oceania, in the small island of Samoa, it's 77 per 1,000. That's not 77 per 100,000, that's 77 per 1,000. That means 7 to 8% of the people that you see clinically in Oceania may have some form of rheumatic valvular heart disease. The World Health Organization estimates that 1% of the children between the ages of 5 and 15 who live in Latin America, Africa, Asia, and Oceania may have some degree of rheumatic valvular heart disease. We wouldn't want to miss that. Say you have a child that comes in to see you clinically, and the child has fever and dyspnea and cough. Well, you'd logically make the diagnosis of pneumonia, and most of the time you're right, because pneumonia is very common in children in the developing world. But what if this child has rheumatic valvular heart disease, and the dyspnea is not from pneumonia, but from congestive heart failure secondary to pulmonary hypertension? Or what if, even worse, the child has endocarditis, and you miss that and send them out? Well, I'd like for you to learn to image simply the valves of the heart, particularly the mitral and the aortic valve. If you haven't completed your basic training in echocardiography, I'd encourage you at this point to stop the video and go on back to the basic module and learn how to do some of the images. As in echocardiography, as in all sonography, we want to see images from different views. So we never view the valves just from one window, but from multiple windows. And for learning in this module, you'll need to learn how to scan in the parasternal long, the parasternal short, the apical forechamber, and the subcostal. Now, some of you may be wondering why rheumatic valvular heart disease is so common in some parts of the world and so uncommon in other parts of the world. For example, the difference between rheumatic valvular heart disease in Western countries or the United States compared with that in Africa or Asia. Well, there may be multiple answers to that question, and in the end, I think no one really knows. Many people have hypothesized that it's from socioeconomic status. As we live in a better environment, a cleaner environment, perhaps we don't get infected with strep quite as much as children living in slums or impoverished areas in large cities around the world. And that indeed may be the case. Other people say, well, in the United States and Western countries, we actually screen for strep pharyngitis. And if they have strep pharyngitis, we treat it with penicillin. And this is just an example of a good practice of medicine in Western countries. However, I suspect that's not the case. I see patients every day, and I don't really think we do that great a job in screening for strep infections of the throat. And I still imagine that the majority of people who have sore throats don't come for medical care. It's also possible that when you look at the epidemiology of strep pharyngitis, that we see that the drop in rheumatic valvular heart disease actually occurred before we started to use penicillin to treat strep throat. So that probably isn't the answer. Other people hypothesize that there's been an antigenic drift of the strep pyogens. In other words, the particular kind of strep that causes rheumatic valvular heart disease is no longer prevalent in Western countries, but it's very common in other countries. And these rheumatogenic strains of strep pyogens seem to be immunologically cross-reactive with heart valves, and that very well may be the case. But there's another very interesting hypothesis, and that is that perhaps rheumatic valvular heart disease doesn't come so much from the strep in the throat, but perhaps from the strep in the skin. Now, if any of you have walked through a village anywhere in the developing world, you've been surrounded by children. And if you look at these children, many of these children have skin infections. These skin infections can be from insect bites that are infected. They can be from burns or wounds that haven't been properly treated. Another hypothesis is these children are infected with scabies often, and the scabies will crust over and have a superinfection. Many people think that perhaps the incidence of rheumatic valvular heart disease is not so much from the strep throat, but from the strep on the skin of these untreated infections. A very interesting and a powerful argument for treating all skin infections in children as we travel around the world. In the end, we really don't know, but probably there's a factor of all of these being involved in the development of rheumatic valvular heart disease in the children around the world.
Before we begin our study of rheumatic valvular heart disease in earnest, let me just take an aside for a second and talk about the effect of rheumatic heart disease on pregnancy. Normal physiologic changes during pregnancy require, on average, about a 50% increase in circulating blood volume. That is accompanied by an increase in cardiac output that usually peaks between the mid-portion of the second and third trimesters. The increased cardiac output is due to an increase in stroke volume and a small increase in heart rate, averaging 10 to 20 beats per minute during the second and third trimesters. However, during labor and delivery, cardiac output increases more in part due to anxiety and pain, as well as due to the uterine contractions, which will cause an increase in both systolic and diastolic blood pressures. Valvular heart lesions associated with a high maternal risk include all those lesions we'll discuss in the following slides. Aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation are all associated with an increased risk, particularly in New York Heart Association class 2 through 4.
Well, let's begin by looking at the valves in rheumatic valvular heart disease, and we'll start with the mitral valve, since the mitral valve is the valve that's most commonly involved in rheumatic valvular heart disease. 75% of people with rheumatic fever will have involvement of the mitral valve, and 85% of people with mitral stenosis will have that from rheumatic fever in the past. And it takes many years to develop stenosis of the mitral valve, sometimes 15 or 20. This is often a disease of young people and adolescents because they get infected when they're young. The aortic valve is the second most common valve to be involved in rheumatic valvular heart disease. The tricuspid valve and the pulmonary valve are very uncommon, and we will not discuss these during this video lecture.
So in starting, you'll see that each of the valves has a little bit of a different problem, its own epidemiology of problems. It's also quite common that the mitral and the aortic valve are both involved in rheumatic heart disease, as thickening of the annulus spreads from the mitral to the aortic valve. Let's start with the mitral valve, since it's the most commonly involved in rheumatic disease. Mitral stenosis is a chronic progressive disease with a mean duration of 16 years before symptoms and with increasing symptoms throughout the years. At 25 years, only 8% are asymptomatic, and death is related to its New York Heart Association classification. There's a 77% survival with those who are minimally symptomatic, in other words, New York Heart Association Class 1, but a 0% survival at 10 years for those with New York Heart Association Class 4. Elevated pressure in the left atrium translates into increased pressure in pulmonary capillaries, which leads to pulmonary congestion and eventually pulmonary edema and pulmonary hypertension. Let's look at a couple things in mitral stenosis. First and most characteristic is the doming or the hockey stick appearance of the anterior leaflet of the mitral valve, and we'll see that in succeeding slides. There's reduced valve opening, seen best on peristernal short view. There's leaflet tip thickening, maybe best in peristernal long. There's commissural fusion, peristernal short is well seen. Subvalvular involvement is common, also peristernal long, and in the apical four-chamber view. There's calcification, which can be seen on all views, and there's what's called the candle flame appearance on Doppler, which demonstrates the degree of stenosis, which can be seen best on the apical four-chamber. In this video clip, we can really see the hallmark of mitral stenosis, which is the doming, or what some people call the hockey stick appearance of the anterior mitral valve leaflet. You can also see several other things in this video clip. You can see the thickened subvalvular apparatus, you can see an enlarged left atrium, and the ventricular hypertrophy, which appears to be concentric in this view, which is also common. In this video clip, we easily see the thickened mitral valve as well as the thickening of the subvalvular apparatus. In this video clip, in the peristernal short axis, we can see the minimal opening of the mitral valve in mitral stenosis. There are a couple other things we can see in 2D echocardiography with mitral stenosis. We can certainly see a thickened aortic valve and aortic regurgitation. We already mentioned in a previous slide that it's not uncommon for mitral and aortic disease to coexist. There's an enlarged left atrium, and sometimes we can see spontaneous echo contrast in severe mitral stenosis, about 80% of the time. There's bulging of the left atrial septum toward the right atria, which translates into increased left atrial pressure. And oftentimes we can see a thrombus, and systemic emboli are very common in mitral stenosis. This is a video clip of a 30-year-old gentleman. It kind of puts mitral stenosis all together with many of the common findings in echocardiography for mitral stenosis. Here you see doming of the anterior leaflet of the mitral valve. You see severely reduced mitral valve opening. You can see thickening of the subvalvular apparatus and an enlarged left atrium and bulging of the left atrium into the right atrium, demonstrating increased pressure in the left atrium. There is also left ventricular hypertrophy, and there is the left ventricle, all signs of severe to moderate mitral stenosis. This is another patient with severe mitral stenosis. Here we see an enormous dilatation of the left atrium. You see the thickened mitral valve with critical stenosis. There's a small candle flame appearance of the mitral stenosis jet. There's bulging of the left atrium toward the right atrium, which means overpressurization of the left atrium, and spontaneous contrast can also be seen. This leads to left atrial thrombus, although there's no thrombus seen in this patient. There's a small hyperdynamic left ventricle, as was in the previous patient, and we suspect that if we were to look at the right heart in this patient, we would find pulmonary hypertension and tricuspid regurg, secondary to pulmonary hypertension. Also, this patient is in atrial fibrillation, a very common side effect of mitral stenosis. These are two different patients with mitral stenosis, and we're calculating the area of the left atrium. You can also visualize severe thickening of the mitral valve in the patient on the left, with significant calcification of the valve. Both patients seem to have dilated pulmonary veins from increased pressure in the left atrium. The left atrial reference area is normally about 20 centimeters squared. With mild stenosis, it would be 20 to 30. With moderate, 30 to 40. And severe would be greater than 40. So the patient on the left with all the calcifications would be moderate stenosis with an area between 30 and 40, even though he has a lot of calcifications. And the patient on the right has severe stenosis and dilation of the left atrium, with an area of greater than 40 centimeters squared. Planimetry is the only objective assessment of mitral valve orifice area, but there is a pitfall. You must cut through the valve at its smallest opening. If you cut through obliquely, the valve will appear to be larger than it really is. There are reference values for planimetry. Normally it's 4 to 6 centimeters squared, and your machine will calculate this for you. Mild is 1.5, moderate is 1 to 1.5 centimeters squares of its opening, and severe is less than 1 centimeter squared. Thus, this patient has moderate mitral stenosis by planimetry. The assumption here is that all of this can be performed at the bedside with relatively simple ultrasound machines. You should be aware that there are other more sophisticated methods for quantifying mitral stenosis that will not be discussed in this lecture. This involves calculating mean pressure gradients across the mitral valve orifice using continuous wave Doppler. And continuous wave Doppler is not available on all machines. You can also measure pressure half-time and the PISA method, which is proximal isovelocity surface area, where the radius of the flow convergence zone is calculated, thus giving both the area and velocity of the jet, allowing us to calculate the mitral valve area. None of these methods, which are a little bit more complicated, will be discussed in this lecture.
Now let's consider our next topic, which is mitral regurgitation. Many people will have trivial mitral regurgitation, which really has very little impact on their health. However, don't be misled by thinking that mitral regurgitation is a benign lesion. There's a 14% cardiac mortality at 5 years for those patients with mitral regurgitation that are asymptomatic, and a 33% chance of having a cardiac event in 5 years. In chronic mitral regurgitation, the heart has to beat faster, has to have increased contractility and an increased ejection fraction to overcome the reverse flow into the left atrium of blood. It's kind of like taking a bicycle tire and trying to pump it up with a hole in it. You have to work harder and faster and longer just to fill the tire, and there's always a continuous leak. Well, after months or years, the ventricle begins to decompensate and fail. The contractility decreases and the ejection fraction decreases, and what we have is chronic decompensated or failure of the ventricle from mitral regurgitation. Well, I wonder what it's like to pump up a bicycle tire with a hole in it. Let's see. I'm actually not getting very far. I wonder if I pump harder, what'll happen. Oh. I wonder how long I can do this. The heart does it for years. I can do this for another 5 minutes.
The mitral valve can be nicely seen in the parasternal short view, and in mitral regurgitation we're going to want to ask several questions. We're going to want to examine that mitral valve. Is it thickened? Does it open? What's the extent of the involvement, and what parts of the valve are thickened and involved? Where's the origin of the regurgitant defect? Is it in the commissures? In this video clip you see a thickened anterior leaflet of the mitral valve, which has a moderate impact on valve opening and a concentric thickening of the ventricle. If we want to quantify mitral regurgitation, we can do so by both what we call indirect signs and direct signs. So let's take the indirect signs first. You can measure the left ventricular dimensions in both systole and diastole. And the way you do that is to take a video clip on your machine and then scroll back to systole and take your internal dimensions, and then scroll to diastole and take your internal dimensions, and your machines will do that for you. There's hyperdynamic left ventricular function, and there's often left atrial enlargement, as in mitral stenosis in the previous cases. There's intraatrial septum bulging toward the right atrium because of overpressurization in that left atrium, and occasionally you can see retrograde flow in the pulmonary veins, which is a little bit difficult to see. I didn't mention in the previous slide, when we do measure the internal diameter of the left ventricle in systole and diastole, that we need to do that in several different views to make sure that we have accurate measurements. We're also going to want to look at the ejection fraction and fractional shortening. All help determine the heart's ability to adapt to volume overload. The left atrium, as we mentioned, will dilate in response to volume and pressure overload, and we talked about making those measurements. Its dimensions help us determine the severity and chronicity of mitral regurgitation. Think about it for a second. If the heart beats 80 times a minute, then it will beat over 42 million times in 1 year. Think of the inner tube example in the elasticity of an inner tube with a hole in it and the bicycle pump. Eventually, after the tube is pumped up millions of times, it will fail. Yet what an intricate and beautiful thing the human heart is. It's incredible. It can continue on for years and years and years. This video clip shows us a patient with both mitral stenosis and mitral regurgitation. Again, not uncommon. And you can see a very thick, calcified valve. Also, the ejection fraction by the eyeball method seems to still be quite high, which is a sign that this is chronic compensated mitral regurgitation. Now let's direct our attention to some of the direct signs of quantification of mitral regurgitation. Color flow Doppler imaging is useful for detecting jet origin, jet direction, and has excellent sensitivity and specificity. Each of the three components of the mitral regurgitation jet, the flow convergence zone, the vena contracta, and the jet profile, can provide a semi-quantitative measurement of mitral regurgitation severity. The PISA method, or flow convergence zone, is measured the same way as it was in mitral stenosis, but is more complicated and is not discussed here. This is an example of how to measure the vena contracta. This is mild regurgitation, as you can see that the measurement is less than 3 millimeters. This is an example of how to measure the jet area. You'll simply trace with your cursor the outline of the jet, and you trace with your cursor the outline of the atrium, and then you apply that as a percentage, the jet percentage to the area of the left atrium. Mild jets are less than 20% of the left atrial surface area, and severe jets are greater than 40% of the left atrial area. In this example, this is mild to moderate regurgitation by the percentage of the left atrial area. There can be a problem with this. If the jets are eccentric, or if they hug the wall, which is called Coanda effect, they can be difficult to measure. I did want to include a short discussion of the PISA method, since it is a method to quantify mitral regurgitation, and it is part of the direct signs. The PISA, which is proximal isovelocity surface area, is not very often used and is somewhat more difficult, and it also requires continuous wave Doppler to obtain the maximum velocity across the mitral regurgitant jet. In the example above, R is the radius of the flow convergence zone, and the area is simply calculated with the formula area equal pi r squared. Use the formula above for the flow convergence zone, and we also use the velocity of the jet using continuous wave Doppler and the aliasing velocity to calculate the effective regurgitant orifice area. Again, the above is given for completeness, and I recommend the less complicated measurements. I did want to mention one or two things about referring patients with mitral regurgitation for surgery. Surgery is best done before the ejection fraction begins to drop to normal or below normal, and also before the left ventricle begins to dilate. These are all signs that the ventricle is failing, and surgical outcomes would not be expected to be quite as good.
Aortic stenosis leads to increased afterload of the left ventricle, leading to concentric left ventricular hypertrophy and eventually to reduced left ventricular function and left heart failure. Patients with aortic stenosis may remain asymptomatic for long times, yet once symptoms occur, the mortality rate increases rapidly, especially for patients with heart failure, syncope, or angina. Nevertheless, usually rheumatic aortic valve disease is moderate in severity and is associated with both aortic regurgitation as well as often with mitral valve disease. Commissural fusion is the hallmark of aortic stenosis and often presents with concomitant mitral stenosis.
This is a graphic representation of what we just mentioned in the previous slide. This shows the long asymptomatic phase of aortic stenosis. But once symptoms occur, patients rapidly progress to significant morbidity and often death within 1 to 3 years without treatment. The sad fact is that often treatment is either unavailable in developing countries or, if available, financially out of the reach of most poor folks, the ones who most often suffer from this disease. Now let's take a look at some of the 2D echo findings in aortic stenosis. The degree of aortic stenosis is often associated with the degree of calcification on the valve. The more the calcification, the more the likelihood that the patient is symptomatic, heralding increasing morbidity and mortality from symptom progression. Leaflet restriction in the setting of adequate cardiac output is the hallmark of aortic stenosis. Left ventricular hypertrophy is associated with increased afterload in the ventricle, also a sign of increasing severity of AS. Hypertension, if present, also increases the load on the ventricle, further complicating things. Coronary disease is also a complication of AS, as the stenosis decreases coronary filling and diastole due to a reduced flow through the valve in systole, and ischemia leads to further impairment of left ventricular function. Left atrial enlargement is also common as the afterload in the left ventricle increases. The left ventricular filling pressures increase, and thus the pressure in the left atrium increases, leading to left atrial enlargement. You can estimate the area of the valve in the parasternal short axis when you view the valve in real time. In this video clip, there are lots of things you can see. There's poor opening of the mitral valve and increased echogenicity of the mitral subvalvular apparatus, designating mitral disease. But also look at the heavily calcified aortic valve and minimal opening of the valve. There is also concentric left ventricular hypertrophy, as well as a degree of left atrial enlargement. So this patient shows signs of moderate to severe aortic rheumatic valve disease, and indeed he was severely symptomatic with chest discomfort and dyspnea on only mild to moderate exertion, even though he was less than 30 years old. This also demonstrates how there is often both mitral and aortic valvular disease concurrently in rheumatic valvular heart disease. In this patient, you see leaflet restriction in the setting of adequate left ventricular ejection fraction, although there is minimal thickening of the valve and minimal calcification. There is concentric ventricular hypertrophy, so there's plenty here to make you suspicious of aortic stenosis. Planimetry is difficult and may not correlate with actual valve area, since getting adequate images is hard and the stenosis may be funnel-shaped. Use planimetry as an adjunct to other measures that we will discuss shortly. It's also important to assess the gradients. As the aortic valve narrows, the velocity increases. If the velocity by Doppler is above 4 meters per second, this indicates severe aortic stenosis. Measure this in the apical 5-chamber view, and with your Doppler, you will need to be right inside the valve. So you will have to change your transducer position to allow the Doppler to be almost parallel to the septum. You can also trace the Doppler curve to give you the velocity across the valve, but this is more complicated for most non-experts. Mild aortic stenosis is less than 3 meters per second velocity, moderate is 3 to 4, and severe, as mentioned above, is greater than 4 meters per second across the valve. When you're scanning for aortic stenosis, don't forget to measure the aortic root. Since post-stenotic dilatation is very common in aortic stenosis, and aneurysmal dilatation, as in this case, can demonstrate significant or severe weakness in the wall of the aorta. Measure parallel to the valve, as in this parasternal long view. Our next topic, which is also our last topic, is aortic regurgitation. In aortic regurgitation, there is blood flow back into the left ventricle, causing the left ventricle to accommodate more volume. There is more forward flow across the valve as more blood needs to be ejected back into the aorta. Thus, we have a volume-overloaded left ventricle, which is dilated and hyperdynamic, with increased afterload and increased left atrial filling pressures. Since there is rapid equilibration of pressure between the aorta and the left ventricle and diastole, there will also be low diastolic blood pressures in aortic regurgitation, which is also what we see clinically. This is a patient with aortic regurgitation with a small eccentric candle flame shooting back into the left ventricle, which would make this minimal aortic regurgitation. This is what we can see in the 2D echo in aortic regurgitation. There is hyperdynamic function of the ventricle as the ventricle is trying to push blood through the valve, but as it does, blood flows back into the ventricle, causing overload. The left atrium is enlarged since it's pushing blood into an overloaded left ventricle. So we have a dilated left ventricle, we'll have hyperdynamic function of the ventricle, eccentric left ventricular hypertrophy with a dilated left ventricle. As mentioned below, there was an enlarged left atrium, and there can be mitral regurgitation since mitral and aortic disease often occur concurrently, secondary to annular dilatation. And as mentioned previously in aortic stenosis, there can be a dilated aortic root. Now let's take a look at how the vena contracta can help us quantify the severity of aortic regurgitation. This is very similar to what we discussed when we looked at mitral regurgitation. If the vena contracta is 3 millimeters or less, then the aortic regurgitation is mild. You remember the case of the small candle flame going back into the left ventricle. That was mild aortic regurgitation. If the measurement of the vena contracta is 3 to 6 millimeters, it's moderate, and greater than 6 millimeters is severe aortic regurgitation. We also had a case of that several slides ago. These are obviously very small measurements, and you can make a mistake by measuring incorrectly and put the patient into the wrong category. There may be also some problems with measurements. There can occasionally be blurring of the color, making it difficult to measure the vena contracta exactly, and there can also be multiple jets, which makes it difficult, if not impossible, to measure the jet width. You can also get an idea of the severity of aortic regurgitation and quantify it as mild, moderate, or severe by measuring the jet width. If you measure the jet width at the LVOT and then measure the LVOT width and convert that into a percentage, you can quantify aortic regurgitation as mild, moderate, and severe. Mild would be the jet width less than 25% of the LVOT width. Moderate 25 to 65, and severe would be greater than 65% of the LVOT diameter. You can have difficulty measuring this if you have eccentric jets or a large aliasing area. This patient has a relatively small central jet. In this patient, in the apical 5-chamber view, the aortic regurgitation is much more severe. Without even measuring the width of the jet and the LVOT width and comparing them and making a percentage, just eyeballing the image, the jet width is probably more than 65% of the LVOT width, indicating severe regurgitation. Another simple way of quantifying aortic regurgitation without making a lot of measurements is just to eyeball the flow convergence zone. If the flow convergence zone is not visible, then by definition the regurgitation would be very small. If it's a small to moderate size flow convergence zone, as would be the case in this video, then it would be moderate, and a large flow convergence zone would be severe aortic regurgitation. Another way to quantify aortic regurgitation is to look for reversal of color flow in the ascending or descending aorta. This is best seen in the suprasternal view with color Doppler. Red flow in this instance designates flow toward the transducer and is normal in the ascending aorta, which is what is seen here. And blue flow designates flow away from the transducer, also seen in this patient, which is normal, but seen in the descending aorta. If there is a change in direction and reversal of flow going diastole on color Doppler, this is a sign of significant aortic regurgitation. This reversal of flow is also responsible for the large pulse pressure difference we see in aortic regurgitation with a low diastolic blood pressure found clinically.
Well, let's finish by just summarizing that we've discussed mitral stenosis and mitral regurg, as well as aortic stenosis and aortic regurgitation, and also those instances where both the aortic and mitral valve have rheumatic valvular heart disease simultaneously. I hope from our discussion you'll see that this is vastly important, particularly for those of you who practice medicine in the developing world or who scan in the developing world. And I hope from today on, when you go and scan children or adolescents or adults in the developing world, you'll remember to take your probe and put it on the heart and look for valve disease. Thanks very much. This is Dr. Ted Kuhn.